Public health is a really difficult thing to talk about because when public health is done right, it's invisible. And that's a big reason people don't know what public health is, because people recognize the presence of disease a lot more than they recognize the absence of disease.
We're change agents trying to make the conditions that form our health, whether it's social determinants or whatever it may be, make those conditions better off.
The beauty of medicine is that, we can focus in on the patient. The beauty of public health is where we actually look at that whole population, that whole community together and figure out how can we best meet the needs.
We are particularly interested in promoting the health of those most vulnerable populations.
Our job is to go out and to do things that protect people, that save people, that make them healthier without them even having to think about it.
Public health is the constant redefining of what's acceptable. It used to be acceptable for young children to die of polio, and then we decided it wasn't. Right now, it might be acceptable for a lot of people to die in violence or of suicide. It may be acceptable for our current climate change situation, but we're going to decide that it's not, and then we're going to do something about it, and that's public health.
For most of the 80,000 generations from the caves till now, infectious diseases have been the primary killer of humans. So early on, particularly when there were things called epidemics or a large number of cases suddenly occurring in a population, people tried to seek answers why. For most of history, it was based in mythology. And really only in the 1800s did we really start to see, in a sense, a kind of organized public health. One of the best examples we often use is what John Snow, a London physician, did back in the 1800s. Well before the cholera bacillus or bacteria was discovered, he figured out that people drinking from a certain well in Soho in London actually were the most likely to get cholera in that area. And without even having discovered the bacteria yet, they went in and took the pump handle off the well, and sure enough, very shortly, the cases stopped. So public health has really been about the collective good. Even sometimes when we couldn't understand exactly why, we knew if we did this, that would stop what was ever happening. Just remember this, in 1900, average life expectancy was 46 years. That took us all the way from those caves 80,000 generations ago to get to 46 years. Today, life expectancy in the United States is about 78 years. That means that for every 2 days we lived in the last century plus, we've gained a day of life expectancy. That is all largely due to public health, not curative medicine.
The School of Public Health really has a long history at the University of Minnesota that predates its kind of official founding in 1944.
The first teacher of public health at the University of Minnesota taught his first course in the winter semester of 1872-73. And that was Charles N. Hewitt, and he was a physician. He had been a surgeon in the Civil War. They were very likely the first public health lectures delivered at any university in the country ever.
The School of Public Health at the U was founded officially in 1944 under Gaylord Anderson. We started with working with the military on a couple projects. One of the most famous is the semi-starvation study that was run by Ansel Keys at the U. He also invented the K ration, which was used for all soldiers in World War II.
The school got established very quickly. It had a Master of Public Health degree. In the early 50s, the very first PhD in epidemiology was established by Leonard Schumann. And the Master of Hospital Administration program, one of the very first programs of its kind that began to train executives for leading healthcare institutions.
So for a long time, we were training most of the public health workers in the Midwest. We were training most of the public health nurses in the Midwest.
By the 1960s and certainly into the 1970s, the configuration of public health problems changed. We began to see a lot more chronic disease as people began to live longer lives through the 20th century. Then we weren't seeing as many deaths from infectious disease.
We went on to do things like major studies in chronic disease. We had studies like Mr. Fit, we had the 7 countries study, all these really groundbreaking studies that are classic now in epidemiology.
Toward the end of the 1970s, we began to focus much more on health promotion, wellness, working with communities, and building partnerships with communities. That change was important. And then in the early 1980s, AIDS emerged. Again, public health needed to change and adapt to the challenges that nature was throwing at us.
One of the biggest changes and ways that the university has grown is by the way that we use data. The university has one of the biggest epidemiological data processing centers in the country.
20 years ago, people were really not very concerned about adolescent nutrition. People were concerned about nutrition of adults and nutrition of pregnant women. But adolescents, there wasn't that much concern, which was strange because this is actually the period of most rapid growth and development in the life cycle. We embarked on this study to learn more about factors influencing the food choices of adolescents and to look at the broad spectrum of eating, activity, and weight-related problems among young people. We've had 2 large studies. One, we studied adolescents for a 15-year period, so from adolescence through adulthood. And now we have a second cohort where we're following adolescents and their families.
We had noticed that as a society, there's been an increase in obesity and other health issues related to that. We also noticed a need in our students, maybe for not always those students that are like athletically inclined and always involved in everything, but the students that really hadn't found their niche in the fitness world or health world or that kind of thing. We were approached by the University of Minnesota School of Public Health. They had done some research related to Project EAT, and they had discovered some alarming trends, but also had really looked at things they could do to help people to prevent it initially so they wouldn't be dealing down the road. And so one of their focuses was targeting teenage girls and trying to help them make some healthy choices, both with fitness and nutrition and mental health, social and emotional health. They came up with this class called New Moves, and it's an all-girls class. I think it's been running in our school now for over 10 years, and it's been extremely successful. The girls have really enjoyed it. They are developing healthier habits. They also realize like, hey, I don't have to be an athlete to be fit or be participating. Project EAT had done a lot of stuff, so there was a lot of data that went into it. It's awesome to see every single girl in my class participating.
You got one more, or are you done? Good job.
They've developed confidence. They know that they can do these things. They're more aware of, like, for example, making healthier choices with foods, the nutrition, that type of thing. And we try to expose them in terms of fitness, like activities they can do for a lifetime.
When you engage in research, it's a very, very slow process. When you see that it's having an impact on families, on adolescents, on their healthcare providers, on their teachers, it makes it worth it. That's the goal in public health. I mean, we want to prevent problems before they happen.
In Minnesota overall, we look like an incredibly healthy state. We consistently rank in the top 10 healthiest states, top 5 healthiest states in the nation. But when you start to pull back the layers, what we see is that people of color, and particularly African American and American Indian people, are suffering poorer health outcomes. Structural racism is a fundamental cause of health inequities. We know we have these social determinants, right? So things like education, our housing, the quality of the jobs we have access to, the neighborhoods we're able to live in, all dictate health outcomes. And a lot of the reasons that people live in certain neighborhoods or only have access to neighborhoods that perhaps are unsafe is because of structural racism.
Systemic racism isn't about individuals, it's about these larger systems. And there can be really great people within these systems, but if the systems themselves were designed to only serve and promote the wellness and health of one particular demographic, which in our country is white men, well, if that system is inherently biased, increased contact with that system doesn't yield a different result. What we're talking about are people's lives, and people's lives at their most precious and vulnerable time. I mean, there's nothing more cherished than child coming into a family. And so what that looked like was people being ignored, being treated poorly.
It was a very traumatizing experience for a lot of people that I knew, or just feeling like they were rushed, or feeling like they had unnecessary complications, or feeling like they weren't listened to.
Having bad outcomes, losing babies.
African American and American Indian babies are twice as likely to die in their first year of life. We also know nationally that maternal mortality is a huge issue right now.
Hearing about mothers who had actually not made it through the process. And that's kind of shocking to think of in this day and age.
When you start to look at things by race, we see that Black women are 3 to 4 times more likely to experience maternal mortality.
I saw the impact that disparities were having on my own communities. I always knew I wanted to put a birth center in North to both create an investment in the community as well as to create a safe space for birthing families in the community.
Roots Community Birth Center is a freestanding birth center located in the Camden neighborhood in North Minneapolis.
I started Roots so that I could provide care in the community, by the community, and for the community.
Her goal was really to invest in a community where we see some of the worst outcomes in birth and maternal health in our state.
Wanting to bring community care back into the community, which is kind of an old-fashioned idea. It's actually not a new idea.
And I found so much empowerment as a mother, as a woman, just as a person. It gave me so much more comfort and confidence.
For the past 3 years, we've been working to understand what Rebecca calls a culturally centered model of care.
You have people who are accountable to community, who see people for who and what they are and their full richness as they walk through a door. And that, amazingly enough, that incredibly low-tech thing actually does mitigate some of these things. What are usually described in the literature as their risk factors become their assets. This is what's working for someone. Their culture is what keeps them well, what keeps them whole.
To be able to have, other women of color there with me, I felt very understood in a way that I never thought that I really would be and hadn't really considered was even possible.
When we work with Rachel around this research, she's really taken that academic perspective to describe that value, taking the words of the people who've experienced our care themselves and turning that into usable data.
My role as a researcher and public health professional is to bring that empirical evidence and that data to light and really help people understand where we need to be focusing our time, our energy, and our efforts. Public health requires a social justice lens because if our goal as public health professionals is to ensure that everyone has an opportunity to be healthy and to have a healthy life, we have to address inequity, and at the heart of inequity is social injustice.
The beauty of medicine is that, we can focus in on the patient. The beauty of public health is where we actually look at that whole population, that whole community together and figure out how can we best meet the needs.
Looking at a population, trying to understand what are their health issues, health problems, and then what can we do as a community of public health professionals to prevent these health issues, safety issues that impact people's livelihoods.
The next thing that public health does is it looks at the system, all the things that might go into that population. And it could be, social behavioral things. It could be environmental risk or occupational risks.
Work is really important. Every one of us here wants to work, and we want to be healthy in order to work so that we can really support ourselves, support our families, and live good lives.
One of the unique things about Minnesota is that we are an agricultural state. We're noted for our swine production, soybeans, and corn. And so that rural community, even though small, is an important part of the economy of Minnesota. And with that, there are some inherent risks. And actually, agriculture is one of the more dangerous occupations out there.
Agriculture is one of the most hazardous industries in our country and throughout the world. And we can look at the farm setting as a really interesting place where both people live and work. It's also, it's the breadbasket. How do we create food for our community, for our world? We look to farmers, and yet look at the types of hazards that are on the farm, and the fact that many farmers really live in communities where there are less resources available for their health and safety.
One of the interesting issues with an agricultural workforce is finding workers. And here in Minnesota, we have a low unemployment rate. And so we try to attract workers, and many of those might be immigrant workers.
Most of the workforce in dairy farms are immigrants, Spanish speaking, and many of them come from Mexico and Central America. They are facing the realities every day, and the shifts are long. Things can happen in a second, and that can affect them for the rest of their lives. Anything that happens to them, it has larger consequences. It affects the family, it affects their income, it affects the farm, it affects the cows.
And these are individuals that are not going to fall into kind of some traditional, healthcare accessibility, either because of language or because of other cultural issues.
How will they know what are the safety procedures and mechanisms? Do they even understand how to safely operate a piece of equipment? Are there trainings available in their language that they can understand?
They want their workers to be safe. They want their workers to be healthy. They want the cows to be healthy and happy. So they want workers to be trained. They want an educated workforce. So they have invited us to be there, and we are there for that reason, that the trainings are free of charge. The trainings have been approved by OSHA. They have been designed thinking about where the workforce comes from, what language they speak, and what will be an easy way to engage the workers. It's very satisfying to give these trainings and to be there with the workers and to learn so much from them. These are very intelligent people. If the worker is safe, if the cow is also safe and happy, it's good for the farm. It's really a win-win situation for everyone.
Changes in behavior at that level of community and populations does often take time. On the other hand, there are also changes that can have almost an immediate impact.
We live in a state that has probably among the most innovative healthcare delivery systems in the world. They're constantly innovating, and that is a hallmark of our healthcare delivery system in Minnesota. The healthcare delivery systems sometimes deploy these improvements and innovations with no plan to evaluate them. They don't have any sort of measurement structure around them, and I think that's a missed opportunity.
We gather lots of information in a clinical setting all the time, but we don't always use it to change the way that we practice.
How do we get the research we do, health services research, to actually have an impact on practice, methodologically and otherwise? It takes a long time from getting the research into practice.
It, on average, takes 17 years to go from bench to bedside, so to speak, and that isn't a viable option. We expect and need and desire things to go much more quickly, and that old model really also didn't deliver the outcomes that we were looking for, so health disparities continue to be a problem.
At the University of Minnesota, we have faculty, staff, and students that are versed in the methods that could be relevant to helping healthcare delivery systems measure the impact of these innovations.
We partner with the University of Minnesota and Hennepin Healthcare to create basically a Minnesota-wide network to train people, embed them in clinical organizations to actually test and demonstrate that impact.
We've pulled together a collaborative of some very impressive health systems, Hennepin Healthcare, Mayo, and the VA, along with the School of Public Health, driving towards patient-centered research outcomes.
The Minnesota Learning Health System was created to train the next generation of researchers who can do embedded research within healthcare systems to try to change the way we deliver healthcare. My project came from my work in the women's clinic at the Minneapolis VA. Women's experiences of sexual assault and trauma was impacting their health and their health care. And one of the most obvious ways that this plays out is in trying to finish cervical cancer screening. It's done with a Pap test. It's a very invasive, intimate exam, and it can be very challenging for women who've experienced sexual assault or trauma. Because I have one foot in this clinical world, I recognize the problem, but my other foot in the research world helped me kind of try to find a solution to it. Cervical cancer is actually caused by HPV, human papillomavirus. We don't have to screen for cervical cancer the way we've always done it. For women aged 30 to 65, we can just screen for HPV. It turns out that a self-collected test could be just as good as, if not better than, the test that's done by physicians. So my research through the Minnesota Learning Health Systems program has focused on trying to figure out how we could implement this alternative screening strategy for women who have experienced sexual assault or have other barriers to getting Pap testing done. Changing that practice is actually a pretty big deal.
Another facet is the sharing of that information, successes and failures across the system.
There's a bidirectional value for us as Mayo Clinic, one, to learn from others, leverage resources that we don't have here, but also then be able to share back what we learn in terms of what works and what doesn't.
I really want to see us tackle the issues that are going to affect everyone globally when we think about the fact that we live in a global connected world now.
In many parts of the world, including our own country, we've had to deal with a reemergence of viruses, a reemergence of diseases that we thought perhaps were once conquered and we didn't have to worry about anymore.
Back in the 1900s, kids were routinely dying from the vaccine-preventable diseases that today we just take for granted. Unfortunately, in this new era of vaccine hesitancy, where parents who never had to experience the horrors of large outbreaks of fatal diseases occurring in their kids because vaccines prevent them today are now opposed to vaccines because, of course, they don't have to worry. That's going to change over time if we keep under-vaccinating our population. We brought the world antibiotics back in the 1930s and 40s. These drugs that could treat against bacteria, parasite, in some cases even viral infections. This year we estimate worldwide that about 70,000 people will die because of antibiotic-resistant infections. I'm not just talking about having an infection, I'm talking about it being antibiotic-resistant, we couldn't treat it. We estimate by 2050 that number will be over 10 million. That'll be more than the number of people dying from cancer and diabetes combined worldwide. So there's one example where public health has to go back now and revisit an old victory because it's slowly slipping out of our hands.
Climate change is one of the biggest things that we're going to have to fight as a species and within public health.
We will see, if we're not already seeing, types of diseases we've never had in Minnesota. As the climate warms, you will now see those kinds of diseases here. We'll see an impact on chronic diseases as well. We will see very heavy rain events, and we will see much more extreme in terms of heat.
There's going to be increased conflict between people. There's going to be reduced clean water to drink. There's going to be issues of food shortage, issues related to allergies, to cancer from increased radiation from the sun, things like that, things that really are going to affect every single way that we live. And we're going to need to put together all of our public health resources to help combat that.
Public health has to play the long game because there's always going to be new challenges that arise and that we have to address. But there's also, I think, simultaneously this sense of urgency of we have to save lives and we have to make things better right now.
I want to help public health keep being invisible. I don't want people to think about their sewer or their trash if they don't have to. I don't want them to wonder if their drinking water is safe or if their food is safe or if they will have a safe future when it comes to things like climate change. But at the same time, I want people to be aware of the ways that they can improve their health and their neighbors' health on a big scale. When public health is working, people think, okay, we don't need to put money into it, but as soon as you stop putting money into it, it becomes an issue. And I think it was Benjamin Franklin who said, an ounce of prevention is worth a pound of cure.
If we would invest in public health, a fraction of what we invest in overall health care, the health of our whole population would be so much better. Higher quality of life, longer length of life, better education and opportunities for our children.
I think it's important that people are thinking about public health when they go to vote, when they think about how money should be spent.
There's no single solution to a public health problem. I can give you a good example of that. It's good to have seatbelt technology, but you really have to educate people to use it. And you need a policy in place. Once we started enforcing seatbelt use, there was a very large drop in fatalities and injuries. Combining technology with a lot of education and a public policy that says you really need to do this.
Public health is one thing that we really need to leave as a gift to future populations, to future people, because think about the things that we inherited that allowed us to be as healthy as we are. Growing up in a world without polio, thanks to previous public health inventions. Think about the things that you want to leave for your children so that they don't have to deal with that. We think about things that right now seem like they're just a part of life. We can sometimes prevent those.
And I want my daughter to not have to think about maternal mortality as a woman of color. I want her to have all of the opportunities she should to have a healthy life.
Our Invisible Guardians is a TPT Partnerships co-production of the School of Public Health at the University of Minnesota and Twin Cities PBS.